Okay, welcome everybody to European Interventional Journal live chat. I'm Waqar Ahmed from Jeddah, Saudi Arabia, and it is my great pleasure and honor to welcome the first author of the BioVasc sub-study, Dr. Paola Scarparo, who did the study from Erasmus University. Welcome, Paola.
Hi, thank you for the invitation.
Okay. So congratulations, first of all, on publication of this study in European Intervention Journal. It is in this last issue. So congratulations on that. And
Thanks.
this paper for everybody is immediate versus staged complete revascularization in patients presenting with STEMI and multivessel disease. It's something we really commonly see. So Paola, I will now give the stage to you. What was the main BioVasc trial? And then we can come to the sub-study. So what was the main BioVasc trial?
Yes, of course. The BioVasc study published in March 2023 is an non-inferiority prospective open-label randomized multi-center trial across centers in Europe that aimed to evaluate whether we should treat the non-culprit lesion in a patient with acute coronary syndrome and during the index procedures or actually during a stage procedures.
Was it index procedure or index hospitalization?
Was actually index procedures versus stage procedures. And stage procedures either as semi-hospitalization or elective readmission.
Okay, that's it's good to clarify that. So now we come to the BioVasc sub-study. Before we come to that, what was the main outcome of the main BioVasc trial?
Yes, of course. I want to just very quickly remind which one were the exclusion criteria that was actually important for the patient. They should have a very clear culprit lesion, because patient with unclear culprit lesion should have been excluded from the trial. As well, patient with previous bypass, unstable patient with cardiogenic shock, and patient with CTOs. Then the main findings of the trial is that actually the immediate complete revascularization was not inferior to stage complete revascularization in terms of the primary outcome. And the primary outcome was a composite of all-cause mortality, of myocardial infarction, unplanned ischemia-driven revascularization, and cardiovascular event. Unfortunately, the investigators were not able to demonstrate the superiority for the main outcomes, but what actually they show is a significant reduction in terms of myocardial infarction and ischemia-driven unplanned revascularization. And very interesting was that at 30 days, actually, they were able to show the superiority of the primary outcomes.
And that was for the main trial?
This was for the BioVasc, yes, for the main trial.
Okay.
And, very interesting, it was actually mostly driven by the myocardial infarction that they observed that almost 40% occurred in the time frame between the index procedure and the planned stage procedure.
So saying that doing the entire procedure in the index would be the best outcome for the patient if you have reduced it by 40% in the waiting time.
Actually, we can have a benefit in risk reduction. Of course, at 1 year follow-up was not superior, but at 30 days, actually, they show a real benefit was actually superior.
Okay. And what are the main findings of this sub-study that you just published?
Of course, we come to our sub-analysis that included only patients with STEMI, where 608 patients, 305 randomized to immediate complete revascularization and 303 to the stage complete revascularization. What we actually show that the main endpoint that was the same in the composite endpoint of the BioVasc was similar between the immediate complete revascularization and the stage complete revascularization, occurred in 7% of the patient with the immediate complete revascularization versus 8% of the stage complete revascularization. And with also no actually significant difference between the single component of the composite endpoint. Interesting that actually, as the BioVasc showed, there was actually a risk reduction of 50% of the primary endpoint during the first 30 days. We were not able to show actually a significativity, but was a trend in a risk reduction of the primary outcome. Probably we were empowered in terms of event. Of course, our was a subpopulation, and events were, as in the BioVasc, not so many.
Okay. And I'm wondering if you can throw some light on patients. Your paper had 25% of patients, so about a quarter, had three vessel disease. So some light on how you treated the patients with three vessel disease.
Okay, so actually our population between the two groups was well balanced between patients with localization of the culprit lesion, LID versus RCA, or complexity of the lesion. Those characteristics as well, two vessel and three vessel disease were well balanced between the two groups. And actually, we didn't find any difference between the 2 and 3 vessel disease. But actually, we, as you mentioned, we had only 20-25% of patients with 3 vessel disease. That actually is in line with the previous trial of ischemic disease and multivessel disease, like the complete culprit trial, as well the recent multi-stars AMI trial. But of course, probably we cannot generalize our result to this specific subpopulation.
Okay, so one final question before we come to the closing discussion. People will ask us about imaging. So how was imaging managed?
Unfortunately, the imaging was performed in very few patients, around 10% of the patients. We actually observed a difference, a significant difference between the group with immediate complete revascularization versus stage. The imaging either IVUS and OCT were performed more often in the stage group, and particularly during the stage procedures. That is actually very interesting data. Thank you for the question. And can be that the operator during a stage and elective procedures feel more comfortable to use imaging to have a slightly long procedures. That also we observe in our characteristic that in stage procedures, actually, the duration of the total amount of the procedures was longer for the stage procedures, as well as the use of contrast.
Okay, so my final thought, and after that, you can give your final thought. My final thought as a practicing interventional cardiologist is when I do a STEMI at 3 a.m., at night when I have to wake up and come to the hospital at 3 a.m., I'm less likely to do a complete revascularization in the index procedure. And most likely I will either bring the patient back during the second day on hospitalization or after discharge, most of the time within the same admission. But when the STEMI comes during working hours and the second lesion is not very complex, that's actually very important, I probably may do it all in the same setting. And it really depends on the time of the day for me and how complex is the second procedure. What about you, Paola?
Yes, I can give you, of course, my thought. Unfortunately, with our study, we were not actually randomized to explore if the stage revascularization during the index hospitalization of during elective readmission was better of the than the index. I can share with you our data that actually, if we consider the immediate setting, so immediate complete revascularization, plus the stage revascularization during the same hospitalization, we observed our outcome was occurred in 7.6% of the population, while in the setting of an elective readmission was just 7.4%. So actually the outcome was very similar. But of course, I want to repeat that those is what we observed, and we were not randomized for this to find out difference between the same hospitalization and the an elective procedures. Of course, my thought is considering the BioVasc trial, the multi-stars AMI trial, our sub-analysis, I would feel safe to perform an immediate complete revascularization if the non-culprit lesion is pretty simple to treat, like one stent lesion that goes very fast, but also in case of an unculprit lesion that can be unstable. Performing OCT, IVUS, for example, a sub-study of the complete trial in a subpopulation that performed OCT, they showed that actually 50% of the non-culprit lesion, they actually are vulnerable plaque. So this one can also be a setting when probably the immediate complete revascularization should be chosen. And of course, we need to consider many other aspects. But first of all, also the patient, that if the procedure is long, maybe it can be uncomfortable to stay longer for the treatment of more complex lesion, longer procedure, patients with kidney disease, those kind of patients, we should actually, I mean, in my opinion, we should actually try to stage. And complex lesion, yeah, for example, very calcified lesion, very long lesion, bifurcation lesion, where you want to use imaging, when you probably want to discuss with the thorax surgeon if actually which one is the best strategy, because we are patient with STEMI, so the culprit lesion should be treated, but the other lesion should also be discussed in another setting. Yeah, there are actually very many situations that can be evaluated. If the culprit lesion was complex to treat with a large thrombus burden, or with not a fine TIMI3 flow at the end of the procedure, then I would prefer also stage the procedure, probably during the same hospitalization. But at the moment, yes, we don't have actually trial on these three kinds of settings. So we cannot actually give advice. What we can actually say is that the immediate complete revascularization in patients with STEMI and as well with ACS is safe to perform also during the index procedure. So the operator should feel safe to perform it.
I think that is a wonderful summary of your study and how you're treating patients in real life. And for our audience, I would encourage you to go to EIJ website now, download the paper, and read the paper. So Paola, thank you very much. Myself and from the behalf of the social media team of European Interventional Journal, thank you very much for joining us.
Thank you for the invitation.